Today is going to be a bit of a learning session and really to give you a few tidbits on what we've generated through the Ontario Dental Association for how we communicate with our patients. Obviously, a lot of our patients are coming in to have their mouths and teeth looked at. They're not going in there with the intentions of having, their tobacco addictions discussed, but we provided and set up some form of program and fact sheets and educational information back in 2013 in line with CAMH and the American Academy of Oral Medicine on how to kind of break that kind of barrier between our patients and how we can openly discuss this aspect of their health with them. So let's get started. Just going to change the slide here. So, generally, why are we doing this? Why is the Canadian government and what Dr. Selby and what CAMH is doing? Why are we all fundamentally involved in tobacco cessation? Why don't we just put it on one type of profession? And I think what we're seeing from the attendance of this group, we as attendees and myself as a speaker realize that it's not just one person's role in healthcare to deliver this message, but it's fundamentally all of our role. So the role as it pertains to the dental professional, how do we make that fit into our practice? How do we transition that into our daily care? And part of what I'm going to be talking about today is going to give you some tools on maybe even if you're not a dental professional, how you can engage in that conversation based on what patients' importance and what they want to, what their goal is for cessation. So we've been involved maybe on a negative stance in the tobacco world for over half a century, not always in the healthiest way. Some of these old ads I find comical now, but some of our grandparents and even our parents recall these ads, and it wasn't that long ago that we were recommending certain brands of cigarettes for our patients, and not only recommending but advertising that. Nowadays, we use these as a comical tool, but back in the day in the 50s, this was common knowledge. Today, we're engaged more in a healthcare preface to engage our patients into preventative care, especially in the dental hygiene world, to provide preventative care for our patients on an oral basis, but also the mouth is a window to our overall health, and as an oral healthcare specialist, I know that when I'm doing an oral examination on a patient, it's not just looking at their teeth. Some of the tissue changes can indicate some comorbidities that may not be diagnosed in the patient, or just showing some signs that that disease is not being managed. Chronic tobacco use definitely is an easy way, and we have tools to diagnose and detect these types of changes in the mouth, and definitely prevention for oral cancer begins with an oral assessment. Keep wanting to use my mouse there. What do we know about smoking and dental health? There's been quite a bit of research that's been done over the last decade, and the Ontario Dental Association coming up in May is going to be giving a 3-day symposium just on updating the dentist and a hygienist on those changes. But we know that patients who smoke are 4 times greater chance of developing oral and head and neck cancers. We know the cytotoxic substances in tobacco and how that affects the oral tissue. I'll be showing you some pictures later on to show you really how that chronic impact looks like in the mouth, and it's quite visual for you to be able to see. We know that nicotine causes vasoconstriction, so not only the cytotoxic substances in the cigarette smoke are harmful, but when we're talking about the mouth, the impact of nicotine on vasoconstriction has a huge impact on gum health, or what we more call periodontal health. And we're beginning to understand even the role of secondhand smoke and even third-hand smoke in our patients and our patients' children, but more importantly, the effects of smoke and secondhand smoke on the impact of gum disease or periodontal disease. So patients may come in and their chief complaint may be that they want their teeth to be whiter. That is actually a common complaint in smokers. Their request is that they'd like their teeth to be whiter. But really when we look inside, we see the devastating effects of the cigarette, the nicotine, and the cigarette smoke on the periodontium, which is our gum tissues, on our tissues of our tongue and our cheek, and some of those signs that can be quite ominous for us being able to predict that somewhere down the road these rather benign lesions may turn into malignancies. Of course, halitosis is very common in smokers. Most of it is because of the cigarette smoke itself, but we also know the drying effects that cigarette smoke causes on the saliva flow can also secondarily cause bad breath. In patients who use smokeless tobacco, it's the sugar content in that smokeless tobacco that can lead to dental decay, which further complicates that with the effect of the gum disease in that area. And I'll be showing some pictures of what that looks like later in the talk. Inflammatory melanosis, this may look scary, but it's just an indicator, and we use this as a tool to educate our patients that, the cigarette smoke is becoming very toxic to the tissues, and it's reacting in a way that we can see quite visually. So some of the work that we've done through the Ontario Dental Association and with CAMH in the past, 2013, we ran a campaign that was provincial-wide, and we tried to raise awareness through our dental patients by publishing a publication that is for our patients on teen smoking. We focused on teens that year in our publications just so that the parents could see what impact smoking and the gateway to the use of e-cigarettes, which we'll further be discussing in this year's campaign. But some of the fact sheets that we find helpful as healthcare professionals in the dental world, and these are downloadable through the CAMH website. They're also downloadable through the Ontario Dental Association website on the patient homepage. And it's the one in the forefront that I actually use most often when I'm giving an oral examination, because it really gives the patient an idea with the picture and some writing on what I'm seeing and what my concerns are for that patient moving forward. These are posters that were published and again are available through the Ontario Dental Association for dental offices and health units to post. I find these very beneficial for our patients when they're sitting in the operatory waiting for us between appointments. They can really see at a visual how much of an impact over the course of 15 years their cessation efforts may make to their overall health. So these publications have been based to help educate our dental world on some of the things that they can add to their practice. Now looking at these pictures down below, there's four. There's one of a tongue. There's one of the roof of a mouth that you can see that has no teeth. There's another tongue sticking out that has some freckles on it, and then another side of a cheek that's pulled open that you can honestly see. You don't need to be a dental professional to see that these don't quite look normal. So we're going to go through some of these and figure out how these can indicate risk for other cancers. And we can use these as a tool as well for educating our patient on the importance of quitting. So oral cancer, this is the world that I work in. I work in a cancer center. My dental clinic is full-time, seeing patients for pre-cancerous lesions. I actually am also the medical lead for our clinical tobacco program in our cancer center, so we receive a lot of referrals for patients who have cancer that are also interested in quitting. So, a lot of what we discuss in our clinic is what would be discussed potentially in private practice or in a medical center, but just with a little bit of a different edge, because we're also focusing on the impact of the chronic long-term use of smoking on oral disease and patients' taste and smell. We use the term dysgeusia in the medical world to discuss taste disturbance. We see this quite commonly in smokers because of the effects of the cytotoxic smoke and the cause and how it impacts the taste buds. Some of us don't realize that taste is really impacted by dry mouth, and I've already mentioned earlier on that smoking does cause a dry mouth, and losing a little bit of your saliva flow does have a huge impact on being able to fight infections, control gum disease, fight tooth decay, but also it has a huge impact on a patient's ability to taste properly. When we look at gum disease is a major cause of tooth loss, and we know the quality of life issues that are surrounded when patients lose some of their teeth or all of their teeth. We know very well in the literature, it's well stated that current smokers have a 4 times likelihood of having gum disease, which we call periodontal disease, and that periodontal disease is the #1 cause of tooth loss worldwide. So being able to address that in our patients who are seeing us often for periodontal care, we may notice that that may have an impact on them if they're wanting to keep their teeth and keep their mouths healthy. Sometimes why patients want to quit is not always the reason why we want them to quit. So I think having this multidisciplinary group of people here, listening to one side of a healthcare profession stance on smoking cessation, I think is really important because our patients may be going into a health unit or seeing their tobacco counselor, and their prime importance is that they're worried that they're going to lose their teeth if they don't quit smoking. So I think this information is beneficial across the board. Now, looking at this mouth, I think everybody can agree that it doesn't look healthy. And this is the type of thing that we see over the long run in long-term smokers. When you get advanced gum disease, the bone around the root starts to resorb or go away. And what we start to see is that the teeth start to get loose and they start to splay. And what you can see here is someone's set of teeth are starting to move quite a bit. If I took an x-ray at this patient's mouth, I would probably notice that there was probably only, 30% of their bone holding their teeth in, and we call this advanced gum disease. And this is common in very chronic smokers that don't have any active dental care. So let's look at smokers' melanosis. We can see the shaded kind of darkish kind of ominous patch on this patient's side of the cheek. This looks a little bit scary because for me as a oral medicine practitioner who sees a lot of pathology and issues of the mouth outside of the teeth, I would have to check to see whether or not I was concerned if this was a melanoma because you can get this in the mouth as well. But these are the types of lesions that we'll see in patients that are chronic smokers, and up to 5 to 20% of chronic smokers will start to develop these kind of melanotic or shaded dark lesions on the cheek. They can be extended onto the gums and onto the tongue. And then we see the advancement of gum disease where we can see this individual, he puts his smokeless tobacco inside his cheek here or inside his lower lip, and you can see the impact of the sugar-containing smokeless tobacco on the exposed root and how the gum disease has become quite apparent with the gum recession in that one area. Smoking-related oral conditions also extend onto the hard palate, and when we look at a hard palate, it should be nice and pink and same consistency and color as our attached gums and our cheeks. When that starts to look white and kind of cloudy looking, this is just from the noxious insults of the cigarette smoke that we know is the primary cause of oral cancer. Now, most importantly, when we look at these types of lesions, these are the lesions that we can really educate the patients in because we know through research and epidemiology and following up on these lesions, the patients who have these white-type plaques on the roof of the mouth are at increased risk for throat cancers, for voice box cancers, and also lung cancer. So I use these types of oral lesions as a tool to educate the patient that these can be indicators and can serve as potential risk factors for development of further head and neck cancers and also lung cancers. Now, what else can patients get other than these kind of lesions that are quite visual, and some of them may be pre-malignant? I mentioned that saliva flow is impaired in patients who smoke, and the primary reason for that is the vasoconstricting properties of the nicotine. When the mouth gets dry, the oral environment changes. and that oral environment becomes of a more acidic pH. And when the oral environment becomes acidic, that's what yeast likes to grow in. So we tend to see yeast infections in chronic smokers because their mouths are very dry. Now those lesions can become quite chronic, and interestingly, they can start to appear like cancers, where even myself can only tell the difference if we biopsy them. Now, getting back to usually patients' prime concern is the tooth staining. We see this very commonly in chronic smokers. This can easily be removed. This is not difficult for us to manage as hygienists or dentists to remove the stain, but it also provides us as a teaching tool to show the impact of the cigarette smoke on the teeth, and we can also use it as a tool to indicate that the stain wouldn't be there if cessation efforts were practiced. Now, last but not least, we're going to move into the cancer world and the pre-malignant cancer world of what I usually see on a daily basis. Our clinic sees all oral lesions through northeastern Ontario, so we do a lot of oral biopsies. And being part of the head and neck clinic and group for our cancer center, our center sees about 110 head and neck cancer patients a year, of which 60% of them are from smoking and drinking abuse. So this is what a pre-malignant or a precancerous lesion would look like on the mouth. You can see a bit of a white patch that's hovering underneath the tongue. That would need to be biopsied because even with that visual examination, I'm not able to see whether or not there's any precancerous changes in that lesion. But moving forward, the whole prime importance of doing head and neck examinations on routine follow-up as a dental professional is that the most common area for cancers is way in the back of the tongue. You can see me pulling out this patient's tongue, and you can see the lesion on the lateral side. That wouldn't be noticed if I just did an oral evaluation without protruding the tongue to see where that cancer was. And most cancers in smokers are found predominantly on the lateral border of the tongue. But you can see that these don't look normal. You can see that they need further evaluation, and the next step for this patient would be a biopsy. So I'm going to pass the webinar over to Dr. Selby to talk about the general health issues associated with tobacco.
Oh, sorry. Okay, sorry, my line was muted. Welcome and to 2016. Sorry, I was talking to myself in this room, and somebody had to come and help me, and I apologize about that. So it's really the tar and the smoke in tobacco that causes most of the harm. The nicotine in and of itself is not harmless, but it's orders of magnitude less harmful and does not account for most of the harm that we see from the use of tobacco or smoking tobacco. So roughly where we see it is obviously because smoke goes everywhere in the body, right from the tissues that it touches as it's going past the respiratory system, through the respiratory system into the bloodstream. You'll end up with, and the areas where the toxins or the 7,000 chemicals that circulate, these are the chronic exposure leads to heart disease, stomach problems, and physical changes that we have been able to see. So often people will say, well, you know, if we stop combusting tobacco, maybe we won't get all these products of combustion like, carbon monoxide and acetaldehyde and acrolein and all those chemicals. So there have been a promotion of, if we use smokeless tobacco, could it be a harm reduction kind of alternative? And one of the things that we have to be mindful about tobacco as harm reduction, in Ontario anyway, is as you go further north in the city, in the province, is that you will notice that oral tobacco use becomes a little bit more prevalent. It's not huge, but it starts becoming a little bit more prevalent. Large population-based surveys aren't able to detect it, but you can detect it at much lower levels in sort of community-based surveys. So smokeless tobacco as harm reduction has often been talked about, and clearly there's something called snus, which occurs is available in Sweden. But in North America, what is often is oral tobacco is generally as dependence forming as cigarettes, and essentially there's a lot of co-use between cigarettes and oral tobacco. And again, generally it's mostly men who use it, and again most smokeless tobacco users started before the age of 18. The issue with oral tobacco use, as you will know, especially in the dental community, is that about 38%, so a little bit more than 1 in 3, will develop oral lesions within 3 years. So really, it's not necessarily the best use. And in many parts of the world, smokeless tobacco is a big, one of the major contributors to the development of head and neck cancers. So when people are trying to promote oral or chewing tobacco as a harm reduction strategy, it does not necessarily reduce harm. And but when people reduce the number of cigarettes that they smoke, it certainly is the right direction. And so the take-home message at that part from people who are smoking or want to switch to, for example, chewing tobacco or reduce the number of cigarettes that they use, it doesn't necessarily have a health benefit, but it certainly helps them a behavioral benefit of moving towards quitting smoking. So when we have people who are using tobacco, we do want to provide them a behavioral intervention, and the reason why we want to do that is because there's evidence. And there's a range of self-help interventions that go from self-help to brief interventions, which are really quick, so less than 3 minutes, intensive interventions, which are a total of 90 minutes, but over several sessions, and of course inpatient by the bedside, are the kinds of behavioral interventions that we can provide smokers. So the elements of brief interventions, and this is for any intervention, is, one way to operationalize the guidelines is to remember something called the 5 A's, and I'll go over them very quickly. Because what you really want in this situation is, are you screening people for their tobacco use? And it can be the way to initiate the conversation. And notice how the question is asked. It says, how much do you smoke? So we're not using closed-ended questions where people are, just saying, do you smoke, don't you? Or you don't smoke, do you? Those kinds of questions are not appropriate. And so really asking this question, whether it's in the pre-assessment questionnaire, whether in the waiting room, but really asking these questions in a way that promote disclosure of their use. The other thing is you can screen by just looking in the mouth, and you'll be able to see the nicotine stains on the teeth. So in many ways, you are able to initiate that conversation by a direct observation, much more than a physician could or a nurse could, because you are looking at the direct deposition of nicotine stains. Now, obviously you have to advise people to quit or reduce and seek permission to intervene, to share information, and then you can assess how dependent they are by asking how soon after they wake up do they smoke. And now this question is really a way to help you understand whether this person might actually benefit from pharmacotherapy, or would they just respond quite equally to behavioral support. Also, in educating people what might be there to help them in terms of the options and how they can go about quitting, whether it is an abrupt quit or reducing. And then, of course, we need to make sure that these we arrange for follow-up, whether it's through the Smokers Helpline or through other means within the family practice or the community. And then, of course, our role as healthcare professionals in having a role in policy advocacy in terms of ensuring that tobacco use is reduced in society in general. So roughly those are the elements of the 5 A's. And a brief intervention, which is kind of like a 30-second approach in very busy clinics, and I understand mostly in dental clinics it's busy, but you do have a long time compared to what primary care has with the patient in the chair. So, but I'll let you know about a brief intervention because your setting might allow for that, or may only allow for that. And here's the one which we do is really look at asking and asking about their smoking status, assess their readiness, and offer them treatment. So it's very quick, and we don't spend too much time trying to spend, whether they're ready, not ready. We just simply say, you're a smoker, assess if there's any reasons not to give them an assistance, medication or what have you, and then provide them that assistance or medication and behavioral counseling. So again, the 5A approach has also been, and a lot thanks to goes to Dr. Saunders, is really thinking about how to adapt it to the busy environment office, making it flexible and easy to implement. So really figuring out of making sure that the standard in the setting is that everybody is asked about their tobacco use, not just in a closed-ended way of or checkbox saying, do you smoke, don't you smoke, but when was the last cigarette? When in the last 6 months have you had even a puff? So that you can capture the occasional users, you can capture the daily users, because it is really time to create a new standard on how we pay attention to something so important to people's dental and oral health, but also their general health as well. So in the history, in medicine, it's often said we want to use this as a vital signs kind of stamp, but clearly this is not what will happen in a dental office. Here's one way in which after those questions are asked of how this could be documented, and I'll point to the bottom about just at every visit, this is how it's categorized, so that over time you can figure out where people are in their quit journey. Clearly, obviously, I'm running into Dr. Saunders one, so I'm going to just hand it back to her so that she can take us through the next piece.
No problem. I hope if anyone can't hear me, just say no, and we'll pick up right away. So, part of my professional obligation is to do a full head and neck examination at everybody's follow-up, and I do that diligently. But also, like Dr. Selby said, asking about their alcohol and tobacco use, and I can honestly say sometimes this is the elephant in the room. We all know it's easy to talk about things that people are open to discuss, but sometimes we're kind of afraid to discuss issues that we may place the patient in an uncomfortable position and at the same time maybe place our relationship with that patient in one that we don't want to be in. But there has been enough research for us to know that we are wrong in our thinking as healthcare professionals in thinking that patients do want us to ask them about their smoking. And we actually just released a study that's going to be published soon in one of our oncology journals stating just that in our cancer patient population that 70% of the patients asked if they smoke and if they wanted help were very happy and receptive to receive that information and actually did follow through the 5 A's thereafter. So those are quite a bit higher, I think, than what we kind of interpret on our own. So moving forward, I'd like to just dispel that myth. So, if I were going to use some of the information that I've given you today for a patient coming into practice or into a counseling session, and if it were going to indicate something about our oral health, I truly do believe that we are all orally fixated, as Freud stated. We are very, we're very concerned about the way our smile looks. We all want white teeth. None of us want to walk around with a missing front tooth. So addressing some of those issues with our patients I think is very valid, and relating that to their addictions and helping them manage their addictions so that they can move forward with their oral health, I think is fundamentally everybody's role. So making sure that our direction and our intent to our patients is clear, that it's strong and personalized. And using an example of a patient coming in, maybe having their teeth cleaned, noticing a filling, but progressive gum disease, and their teeth are starting to turn yellow, I may address with the patient that, their checkup, we need to do some further treatment, but if maybe I can address a few questions that may help address why the patient is in that position, and then just ask, how much are you smoking? Sometimes I even use the wording, you're here often enough, I see you often enough, I'd like to reserve this portion of my appointment time with you to just sit down and talk with you on some of the things I'm seeing that is changing in your mouth that seems to be really strongly related to your smoking. That kind of opens up that, and asking how the patient feels about that, if they're receptive to wanting to know more. So I think that keeps it personalized. It doesn't have to take a lot of time, like Dr. Selby said. Most of my 5 A's, or at least the 3 A's, the first to assess and advise, is in less than 30 seconds. We do carry through with a full assessment, and we do arrange for a tobacco intervention and pharmacotherapy, but it doesn't have to be your primary role. But asking the patients the fundamental questions so that you can have it documented. And if the patients don't feel comfortable about completing all of that, and if they state that they're not overly confident or motivated, and you don't feel that you have the skills to go on from there, you can always open the conversation to saying, is it okay if I ask you these same questions at the next visit, because I just care, and I'm going to see what I can do for you in the meantime. Those types of things don't close the door, and they allow you to have some time in the back room to figure out, can you forward these patients to the health unit? Is there a smoker's helpline that you can have access to? I think the majority of the group that are attending the session here today already know what those resources is, so it's just finding a way for you to develop the confidence in yourself and the motivation in yourself to provide those messages and information to the patient. So I'm going to switch it over to Dr. Selby to discuss the next slide.
Okay, so what do we ask during an assessment after we've gone beyond, beyond figuring out that they smoke? We want to know whether they're having any withdrawal symptoms, and this is very simply asked by about, what's the longest you can go without a cigarette? What happens when you don't have a cigarette? Typically, withdrawal symptoms typically have a lot of cravings to smoke. I mean, most people will say, I go too long without a cigarette, I have cravings to smoke. They may describe loss of concentration, feeling irritable, feeling restless, agitated. But most people don't let it get too bad, and they tend to smoke right away. One other way of knowing about withdrawal symptoms, especially in heavily dependent smokers, is if people are waking up in the middle of the night to have a cigarette, and then when they have a cigarette, they feel calmer and they can go back to sleep. So because nicotine on average is the half-life of how long it takes for half the amount of nicotine to get eliminated from the body is about 90 minutes, people need cigarettes to help maintain those levels of nicotine through the day. So people are going in and out of withdrawal all the time, and you might notice that some of your patients are getting kind of restless, especially during a long appointment. In terms of what they've done to quit before, ask them about previous quit attempts. Have they used any nicotine replacement therapies, medications called bupropion, varenicline, and behavioral, or any behavioral interventions? Have they called the Smoker's Helpline? Have they done any self-help books? What do they know about quitting smoking? And again, asking them what happened when they tried those those various interventions. Did they work? Did they cause harm? And again, last thing that we want to know is who are their supports outside who might support them quitting smoking, or who might come in their way of them quitting smoking. We know that if somebody's living in a household where somebody else is smoking, they're half as likely to be successful. So ensuring that we pay attention to that other half of the supports in people's lives is very important. The other thing is, we also know that current day smokers tend not to just be healthy smokers. Most of them are more likely to have some sort of comorbidity. And again, these comorbid factors can affect the outcome. And especially if they have these comorbid factors, you may consider referring them to more specialized services for longer interventions. So, for example, people who might have cardiovascular, respiratory, or cancer diagnoses may require more intensive interventions, may require more different types of medications and supervision if you're going to use some of the medications, similarly for pregnant women. Clearly, the use of other substances comes in the way of being successful, and so people are also drinking alcohol, and especially they're drinking above guidelines. As you know, the risk for aerodigestive cancers with alcohol and tobacco together is more than either one alone. So they have a multiplicative risk for aerodigestive cancers, especially oral head and neck cancer. So asking about alcohol is extremely important from a risk perspective, but it's also important because when people are drinking, they are less likely to be successful in quitting smoking, and alcohol serves as a trigger to smoke. So really getting them to consider, obviously if they're heavily dependent, then you refer them to a treatment program. But if they're just, what we would call social drinkers, drinking above guidelines, get them to consider stopping alcohol, at least for the duration while they are quitting smoking. Clearly, psychiatric diagnoses like depression, anxiety, whether it's lifetime or current, will interfere with somebody's ability to be a successful quitter if they try to quit without the appropriate supports in place. And the appropriate supports are pharmacotherapy to quit smoking, plus behavioral support, and so clearly making sure that if they get the access to those things. And for those of you who work with people with severe mental illness, and clearly we have our dentist here at CAMH works very closely with this patient population, they do need specialized services while they're trying to quit smoking. One of the things that we know is that smokers, they're not coming to the dental office to quit smoking, but it doesn't mean that the intervention that you do doesn't get them to start thinking and wanting to make a quit attempt. So really assessing somebody's readiness to quit is more important after you've had a conversation with them rather than just before. A lot of times people will ask them before, are you ready to quit smoking? And the person will say no at the beginning of the interview, but after you spend time with them or you've discussed with them and educated, you may have softened them up to making a quit, ready to quit. So if you've got somebody who says, yeah, you know what, I'm willing to make a quit attempt, we know from research that those who are willing to set a quit date within 30 days, in fact, even better, within 2 weeks, are much more likely to follow through. So ask them if they're willing to set a quit date within a couple of weeks, and ask them to make a serious effort, which means they plan for those 2 weeks in making cigarettes like a conscious act, again, not just mindless smoking, so they monitor their cigarettes. They don't smoke indoors anymore. They don't smoke in their car anymore, their vehicle anymore. And they're hanging out in smoke-free places more and monitoring every cigarette they have. That is sort of the preparatory work that they can get going and then plan for, on that quit date, what pharmacotherapy will they be taking and what behavioral support will they have in place and how have they transformed their living space to be, not act as a trigger to smoke anymore. It's really important to emphasize complete abstinence as the ultimate goal. Not everybody's ready to get there, but that is really where we want people to go, because we know that if somebody is able to quit for 24 hours without a puff, they're much more likely to make 7 days, and if they make 7 days, they're much more likely to make 30 days, and if they make 30 days, they're much more likely to make 90 to 100 days. And the research suggests that if people can go 100 days without using tobacco at all, not even a single puff, their risk of relapsing goes down to less than 5%. It doesn't go down to 0, but it really increases their chances of becoming permanent non-smokers. Unfortunately, you have to do work to get to those 6 months. So it's really very important for them to understand that just because they've stopped smoking for a week, they're not out of the woods. It takes approximately 100 days before that. So clearly in the intervention, you can certainly get them to think about a quit date, how to stay the course, provide self-help materials, consent to either fax them to the referral to the quit line, to provide counseling, and or refer them to the website where they can do an online program. So what are the various treatment approaches? have seen many things come and go. For example, before the lozenges appeared, people were making nicotine lollipops, and there is no evidence that they work, but they were just put together, and because people couldn't chew gum. People have tried acupressure, acupuncture, filtering systems, hypnosis, light therapy. The evidence for them is tenuous at best, and it's no better than placebo. And so one of the roles that we have to do is make sure as healthcare professionals, as regulated health professionals, is endorse and implement evidence-based treatments. What to do on the day of the quit day? So clearly, in preparation of that quit, as I said, inform supportive family and friends, inform the supportive tobacco users to make sure that they don't trigger them, leaving their cigarettes around, offering them tobacco, etc. And clearly this is called reducing the stimulus that makes you want to smoke and make it harder to access tobacco, so getting rid of all the triggers. Clearly negotiate tobacco-free homes, and again plan for distracting activities and monitor smoking, as I said. We know that most smokers in the initial stages, in the first week, especially day 3, it's really the irritability and the acute nicotine withdrawal symptoms that get them to relapse. After that first week, it's really the cravings, triggers, and activities around them. But what seems to persist for a long time, for months and years later, is that the vulnerability to go back to smoking occurs when people are feeling stressed. So making sure that they engage in distracting activities like physical activities, scheduling time for hobbies, relaxation, and enjoyable social activities is extremely important. So really this is important for us to start getting people to understand that handling stress in a healthy way is an extremely important relapse prevention activity. With respect to weight gain, people can be often concerned about weight gain. I shouldn't say typical weight gain. The average weight gain in some individuals can be up to 10 to 12 pounds with cessation, but it's not a given. The health risks are minimal, but again, here's the double-edged sword part of it. If people gain weight, they're much more likely to be successful. And some of the reasons for that is because often when people are quitting a drug of abuse, they use food as a way to substitute, and then therefore are not going back to the drug of abuse, and therefore they gain weight, but they also don't go back. What we do is get people to think about various ways in which they can eat healthy, reduce the caloric intake, and still get that oral satisfaction through low-calorie foods, sugar-free gum, etc., xylitol-containing gums, etc., to see if they can manage their need for oral gratification in another healthier way. Pharmacotherapy like nicotine replacement gums, lozenges, inhalers, etc. and bupropion will delay but do not prevent weight gain. So the considerations are, for some people we may say start a fitness program right away, start a nutrition program, so you integrate both together. For other people it's really important to focus on cessation right away and then target nutrition later on. So these are the various ways in which we will address those concerns. I think I need to change the slide from consider pharmacotherapy to offering pharmacotherapy, because the reason why I'm saying that is when we do the guidelines and we look at all the evidence base, the strength of the evidence is very strong and the quality of the evidence is very high. So which means it gets like a 1A recommendation. And when something has a 1A recommendation, we as healthcare practitioners have to have a really good reason for not offering it to a patient. And so we really need to make sure that we offer all patients, especially those who smoke 10 or more cigarettes a day. And that's, in the literature, 10 or more cigarettes a day has been considered heavy users. And I think those are the individuals who we would definitely offer pharmacotherapy. And some people, for example, if you're using nicotine replacement therapy and they're smoking 25, 30 cigarettes a day, might need higher doses of combination pharmacotherapy. In considering pharmacotherapy, we obviously see what's worked before, what hasn't worked. Did they use it appropriately? A lot of people will tell us, oh, I used the patch, but they actually haven't used it long enough. And then we will pay attention to the next pharmacotherapy where we go into this in detail. With respect to follow-up, it's really important to figure out some way to create follow-up, whether it's yourself, and it can be by phone or through the Smokers Helpline. is that 1 to 2 days prior to the quit date and 1 to 2 weeks after the quit date, and a monthly while on meds and 3 to 6 months follow-up is appropriate. And it doesn't have to be face-to-face, but it has to be in these various formats that I put forward. When people have a relapse or a slip, you can say, look, you're stopping for now, and if you have a slip, use that as a learning opportunity to prevent it from becoming a relapse. Always, if you have a fall or a slip or even a full-blown relapse, remember you need to get right back on track. And that helps people understanding that quitting is a process and not an event. When you refer, clearly, if people have tried low-level interventions, brief interventions, they're not succeeding, they clearly have comorbidities like cancer or really reasons they need to stop right now, send them to intensive treatment. If they've got complex medication problems, high comorbidities, they're highly dependent, and they're not responding to simple interventions, they definitely need to be referred on for more intensive care. So from the guidelines, this is just a model that you can see, putting it all together of how to approach every client or patient in your practice, is that ask everybody if they're never a user, congratulate them, do primary prevention, especially in young people who've never taken up smoking or using any kind of tobacco-related product. Reinforce the primary prevention. Ask ex-users, about preventing relapse. If they're current users, advise, assess. When they're ready, assist them. If they're not ready, motivate them to get ready. And when they're ready, assist them to make a quit. And so keep people in that process of quitting. Clearly arranging for follow-up, and if they're absent, providing relapse prevention. And so it tells you that this is a cyclical activity, and it's not a one-time intervention in somebody. In fact, people are going to need a lot of interventions, often more than once, and that's the nature of the game. It's not a single intervention for somebody in their lifetime. So I'm going to hand it back to Dr. Saunders to take us to the next slide.
Sure. So before we end, we've got about 9 minutes before we have to return to our work. Just reflecting on a few next steps. How maybe what we talked about can impact you in your clinical practice. I understand a large proportion of you are dental hygienists, but others are from health units and other organizations. And, thinking forward, and seeing how we all enjoy our mouths, smokers also do, and trying to think and engage patients with that in mind as well is something I think that we can move all towards in a more thoughtful process. So if there are any questions, there was a case study that Dr. Selby and I were going to work through. If there's other questions, though, we'd be more than happy to address those at this time.
And I think people can pay attention to the chat. You can type in your questions in the chat, and we'll get to them. So I think pay attention to some of the posts that we have there.
So let's go through the case discussion. Sarah is a 29-year-old patient who's presenting with severe gum recession, which would not be usual for someone in her age group. Her chief complaint is the color of her teeth. So she's got about a 15-year smoking history of half a pack, so we can relate that to about maybe 7.5 pack year smoking history. She knows what her triggers are, and I always congratulate patients actually at this point if they know what their triggers are, because they're ahead of the game if they know what's triggering their need to smoke. And making people feel validated when you're talking about their addiction, I think, is really important, and having them realize that they probably know more about it than you do, and working together as a group and not just being the dictator going through, I think, is really important. It allows the patient to have some control and autonomy over what they want to do next. So she knows her triggers. She has concerns with weight gain, and most women in that age group do with quitting. Like Dr. Selby has said, I fully agree about the pharmacotherapy and the level 1 evidence. I don't believe that it's really easy to get patients to quit unless they're superhuman without pharmacotherapy, or if they have really good support networks around them. But the importance of her quitting is a 7 out of 10, which is quite high, and her confidence is a little bit lower at 6 out of 10. Maybe one of the questions I may ask her is what makes her a 6 out of 10 in confidence and maybe not a 3 out of 10. And then you'll be able to gauge really where she is at that confidence and really what her barriers are. Peter, I'm not sure if you have anything to add to that.
No, I think that's good. I think that's a good overview of it. And so I think we need to, maybe we should go to the next slide and get case discussion going in terms of what are the questions for Sarah. And here's where we have to think about asking you as you can, look at the chat and type in there, what are the strengths and challenges evident from the assessment information? What information is missing? What areas of the assessment warrant further exploration? And are there any discrepancies in the information you've been given? If so, what are they? How does this impact your intervention? Developing a plan for Sarah, what would you recommend? So why don't we just go with question 1 to start, and how many minutes? We'll have to do this fairly quickly because we have about 5 minutes left, but let's see how far we can get.
Okay. So maybe we can, yeah.
No, sorry. Back to the question. So maybe we'll just quickly speak to them. If you
Sure.
look strengths and challenges evidence from this this case, you can see that they already have something that could be made worse or caused by their smoking. And here's the other thing, started smoking at a very young age of 14, so you've got like 15 years of smoking. Smoking 12 to 15 cigarettes a day. The counter aspect is this is where the person drinks is the weight, has concerns of weight gain, is anxious, drinking, and is really liking cigarettes. But on the other hand, you can see the contrast of wanting better health and better oral health, and wanting to break away. But what you're seeing here more is this middling of importance and confidence, and so, in this situation, we don't know whether she's, when you ask, has she tried to quit, what has she done before, we don't have that information, and that would certainly help guide us as to what we could do to help her get tobacco-free. So I think that's part of the information that we're missing. The strengths that she has is that she, as I think Dr. Saunders pointed out, she's saying to you, these are my triggers. She's able to identify them. She's able to identify both sides of the argument. When somebody's able to do that, we often say that the reason why often those people are not making quit attempts is because they are ambivalent, which means they are stuck between both sides of that argument. And so helping them to tip the balance of the argument in favor of quitting often has to do with improving confidence to quit. Because most people don't take action despite knowing something is bad for them, is if they don't feel confident that they can succeed. And so that's our role in helping people see the potential of being successful ex-smokers. So we don't know what other supports there are around her. We don't know if there are other people in her home who are smoking. We have no idea whether she's tried to quit before, for example. And so we need to explore that further with her. And in terms of discrepancy in the information, we don't try to go and figure out whether people are misrepresenting or not misrepresenting. I mean, if something doesn't fit right, I will simply ask, what's going on. In terms of, if people are really worried about something that is fairly innocuous, like you're telling them about gum recession, but then they're only worried about teeth. And this happens all the time. We see people who come in with, significant heart problems, but really they're only worried about their smoking and maybe some future risk of COPD, but they've already got heart disease. We try to help them understand what that discrepancy is and try to get them to square that.
Yeah.
And so that, so you're sometimes saying, they don't necessarily appreciate or understand the severity of in this situation, what it's doing to their gums. But they're only focusing on more the cosmetic. So maybe Dr. Saunders, you can say a little bit more about that and how you deal with that specifically in the situation.
Well, and Peter, that's so valid. I mean, we're looking at something else that's more concerning for the patient, but we have to always focus on the patient. And with that in mind, I would address her concerns about her teeth, but then I'd let her know what my concerns were with her overall health and the other impact that it's putting on her as far as her risks for oral cancer. And maybe that'll actually change what is important to her, because she may not be knowing in what the other more severe concerns are. I think another thing that's fundamentally important, what may be missing in this case study for us to assess how addicted she is to her cigarettes, is to ask her when she's having that first cigarette in the morning. It gives us an idea of her addiction and the height of her addiction, so that we can actually address why we've asked that question, how it lets us know how addicted she is, and whether or not really pharmacotherapy should be fundamentally involved in her treatment plan. So, moving forward, the mouth is a gateway to overall health. We're focused a lot on today's with oral health, but you can see with Dr. Selby and I both speaking, one dentist, one physician, we see that it goes much beyond that, and the overall impact on what we can all achieve with patients with these types of situations.
And, we have about a minute, we actually over, so we're going to bring this to a close.
Yeah.
I'm just going to say that the questions that have come up in the chat, we will curate them and we will definitely create responses to them. And I think I'm going to just keep moving through the slides because there are resources available to you at TEACH, at Canadapt, Pregnet, upcoming events that we certainly want to make sure you know about this, and Dr. Saunders she's the leader behind this, and she does the movement. She's created this movement in the dental community around this. So it's really really good to see this, and the ODA in the annual spring meeting will have an essential strategies for tobacco cessation in dental practice, and there will be 2 lectures and a workshop. And again, please link to the evaluation and post-learning assessment, and if you need any further help, email Parizad at the email there, and make sure to email Parizad, especially if you were a group and there are more participants at your site who participated today. Okay, and lastly, the dental webinar part 2, where we're going to be talking about pharmacotherapy, and we'll make sure that some of the questions that came up today, we create a way to get answers back to that as well. So have a great rest of day and weekend, and thank you so much, and we'll see you back for part 2.
Great.
Thank you very much, and thank you, Dr. Saunders, for your time and your expertise.
Thank you both, Dr. Peter Selby and Dr. Saunders, for today's great presentation. If anyone is still on the line, I see some questions here regarding the slide deck. You can download them if you just go to the bottom right-hand side of the screen under File Share, click on the name of the document, and click Download Files. Okay, so thank you everyone again for participating in today's webinar. We hope you enjoyed it, and stay tuned for Part 2.
And when is Part 2?
Part 2 is back on the slides. If you hit back, it's February.
I don't think the date showed up.
Oh, it's not there. Right, it's February 12th. And registration is currently open.
Okay, great. All right, thank you very much. We'll see you then.